Okay, hello, I am here with Dr. Perkins today, talking about Parkinson's disease. Nice to talk to you today, and we'll start, when is the time and of where Parkinson's symptoms start to show?
Well, that really raises the question of what Parkinson's is. The first thing I'd like to do is define what Parkinson's is. Parkinson's is a syndrome, which means there's no one specific thing that causes it. There's a host of things that cause it, causing really four cardinal manifestations. The first would be resting tremor. The second would be what's called bradykinesia, which is slowness of movement. The third is rigidity, and we'll talk about the rigidity in a little bit. And the fourth and last is postural instability or difficulty walking. Along those lines, it's interesting to note about what age it normally starts. It generally starts at 70 is the average age. It's rarely seen before age 40. As we age, the chance increases over 60. So there's 10 new cases per 100,000 people. And in any given population, about 1% of the population has the disease. When we look at risk factors, it's very difficult to sort that out as there's not been one genetic link that's caused it, although we know that it's more common in men than women, and there's certain other risk factors such as trauma to the head, in particular with boxing, that can lead to this.
So what is dopamine and how does it tie into the Parkinson's disease?
So fundamentally, when you're looking at what's causing Parkinson's, and you look in the brain, it's very difficult to describe without a series of figures. But if you can picture the cortex of the brain, which is where your body tells your limbs to move, and it goes down your spinal cord out into the nerves and to your muscles. There's a sort of a regulator on that helps coordinate that movement, and that's where the basal ganglia comes in. In that basal ganglia, there's a neurotransmitter called dopamine. Dopamine's best thought of. Really, it's a small molecule. It's organic molecule. It's like epinephrine, frankly. In fact, in other aspects of medicine, it's used to push blood pressure up, increase heart rate. In fact, it's very similar to epinephrine. It's one of the 200 plus neurotransmitters in the brain. What happens in Parkinson's disease, though, is the cells that have receptors for dopamine in that basal ganglia that help modulate or help modify how we move and make that movement fluid and not stuttered or slow, like in Parkinson's, is downregulated. So that these cells go from about 550,000 cells to only 100,000 cells, and that's when you start seeing symptoms of Parkinson's. And that's thought to be how dopamine plays a role.
Okay. Let's see. What is the actual what is actually happening in the brain for Parkinson's to go on?
So that speaks to what's called the pathophysiology and the pathology of what's going on in Parkinson's. As we talked about, dopamine plays a key role. Interestingly, in individuals that are suffering from Parkinson's, what occurs is the body tries to upregulate the dopamine in the brain by increasing the amount of a hormone that increases the amount of dopamine that's present in that area. So the area that occurs in, what's happening essentially is cell death. The cells are dying, and then scar tissue forms in this area called the basal ganglia, which really is a group of about 20 different nuclei or areas of the brain that are dying. It's unknown why they're dying. In fact, that's the whole point about Parkinson's disease is whether or not it's truly a disease and caused by one entity, or rather it's more of a syndrome caused by a multitude of things. For instance, drugs, toxins, trauma like boxing can cause Parkinson's-like syndrome, and then Parkinson's disease itself, which is thought to have some role of two factors, environment and genetics, that go into causing the symptoms mediated through the basal ganglia.
Oh, and also I did some research and heard that when they're trying to test things as surgery, they really can't do anything because it's so far, or it's not so far into the brain, but it's into the brain to the point where if they do try something, it'll most likely injure the person, possibly.
Absolutely. The basal ganglia is actually a very deep part of the brain. It's what's what we typically think of when you see a brain, the lobed, convoluted ridges. It's deep in that. It's centimeters deep. It'd be nearly impossible to hit strategically, although so surgery really is not playing a major role in the attempts to try to prevent the manifestations of the disease.
What is the first procedure when someone's diagnosed with Parkinson's?
Oftentimes when we see medical problems, we like to diagnose them with certainty with medicines, or with lab values, or doing some neuroimaging testing like a CAT scan or an MRI. There's none of that with Parkinson's. Parkinson's is exclusively diagnosed clinically, which essentially means you need to know what the symptoms are. So you look at the symptoms and you look at the patient, and then paradoxically, really in the 21st century, the next thing you do is introduce a drug, and if the drug works, that supports your hypothesis that indeed is Parkinson's. As I told you earlier, there is a host of things that look like Parkinson's that are not Parkinson's, and the response to treatment is really imperative to validate what you were thinking, that indeed this is Parkinson's.
So is there a difference between tremors and actual disease of Parkinson's?
That ties in nicely with the last question. So when we clinically look at what the diagnosis is, the first thing we see usually is a unilateral tremor. So the clinical manifestations, the clinical symptoms that we see is a tremor. It's usually asymmetric. The tremor is a resting tremor, which is one of the few resting tremors in medicine. Most tremors are intentional, meaning when you move, your tremor gets worse. In Parkinson's, when you move, your tremor gets better. So most of the other tremors, such as essential tremor, which is an inherited problem, gets worse when you move. And that's the way most tremors are. The other symptoms that people have with Parkinson's that help you make the diagnosis is rigidity. The rigidity Parkinson's patient, rigidity is resistance to passive movement. So passively moving your arm, there's a certain rigidity, a cogwheeling, almost like a sprocket, and the muscles release. It's very specific to Parkinson's. The third is what's called bradykinesia, which is slowness of movement, whereas individuals that are normal can rapidly alternate movements quickly. In Parkinson's disease, it is much slower. It's manifest in tests like I'm doing now, but we see it in patients more in what we call inanition, where they volitionally, they just don't want to do things, and the reason they don't is because they're so slow. So we see it in their gait, we see it in how much they want to interact with the environment. They're more sedentary. There's a host of other things that can go along. You may have heard of postural instability, people falling because of Parkinson's. There's a dementia that can occur with Parkinson's. A classic Parkinson's feature is something called mask faces. So even if you tell a joke or you tell them something very sad,
just bland.
It's just exactly very blank and bland.
Okay. So how much of a Parkinson's patient's life is affected by this disease?
So when Parkinson's is initially diagnosed, the question then becomes, how important is it to treat? Initially it's a one side of the body, and if it happens to not be the dominant side, for instance, if it's affecting more the left side of a right-handed patient, oftentimes they can go years without treatment. There's a theory about treatment that possibly some of the treatments might actually worsen the disease. It helps the symptoms, but worsens the disease process. So right now, the thinking is to try to minimize how much treatment goes on early until it starts affecting their life. So the way it would affect their life is sort of socially embarrassing situations where maybe patients would spill when eating, a tremor that's noticeable when they're working, the inability to work because of the tremor, risks of falling. So that's when we start talking about treatment.
So really, as it goes on, you're almost you're getting a disability where you need someone to almost take care of you almost about every aspect of the day?
Sorry. Yeah, as the disease progresses, that's what happens. Is that there needs to be a caregiver in the home that helps the patient do day-to-day tasks, what we would call activities of daily living.
Okay. So, if you were to have if you do have Parkinson's disease, what medication or what activities do patients do to, minimize the tremors or possibly try to cure it?
So the biggest thing is what we know about the pathophysiology and the role of dopamine. So the pharmaceutical companies have come up with a drug called levodopa, which you take by mouth, it gets absorbed, it's converted into dopamine in the brain, and that helps reverse some of the side effects. They also give an inhibitor of the enzyme that breaks down the dopamine, so the dopamine stays around longer. There's a host of other medications essentially predicated on that premise that increasing the dopamine levels in the brain make it better. Conversely, there's another theory. It has to do with acetylcholine. Acetylcholine is another neurotransmitter, very common, found in the end plates of nerves as they interact with muscles, but also in the brain. And it's thought that the relative amount of dopamine and acetylcholine dictate how much of the symptoms of Parkinson's you have. So more dopamine is better and less acetylcholine. Okay. So they do give acetylcholine blockers, so they decrease the level of that as well. And those are three of the very common of drug treatments. There's a couple others, but those seem to work the best.
Okay. And do you think at some point that it'll be a guarantee that someone will get Parkinson's disease, like at a certain age it's just going to be set, or do you believe that with time, technology, that we can possibly cure Parkinson's disease or lower it?
So I don't know that Parkinson's will be a guarantee as you age. There are some diseases that people tend to get regardless if they live long enough. Alzheimer's dementia seems to be one. Where the chance increases significantly as we age, and very few people escape it at the upper ends of our age limit. Parkinson's does not seem to be like that. The hard part about curing Parkinson's is that until we know the absolute cause of at least the disease state, whether it be genetic or a confluence of other environmental factors, it'll be hard to truly cure it. But I think if they do find that gene with technologies that are really literally 50 and 60 years away, that's going to be something that they may be able to cleave out the bad gene in the genome, and with viral technology right now, insert another and potentially prevent, which would effectively be the cure, which is the prevention.
Well, thanks for your time today. Glad to talk to you. Yep, thanks. Yep.